Thank you. Again, my heartfelt thanks to David Cornfield and the organizers for giving me the honor of being able to show you and talk about some of the features of bronchopulmonary dysplasia and some of the wonderful work that Bill Northway did. So it was in 1967 that Northway and colleagues described the evolution of RDS to chronic pulmonary changes in ill premature infants who were treated particularly with high oxygen and artificial ventilation, coining the term BPD. So Bill Northway really was a prime example of something that we see occasionally from time to time, and that is that everybody sees the same thing time after time, but only a singular person perceives it in a special way that everybody says afterwards, "Oh, why didn't I think of that? Why didn't I see it that way?" Remember again, as people have pointed out, that this work was before the availability of surfactant and modern ventilation strategies. And Bill Northway really was not just a one-trick pony. He really continued over many years to make many more important contributions to the understanding and evolution of BPD. So over time, of course, BPD has been recognized as a much more complex multifactorial interaction with multiple genetic and maternal or acquired antenatal and postnatal factors that affect the lung. And we're looking at development, injury, and repair superimposed. And other people will tell you more about that. So this is an example of a case from my very early days in radiology of a 30 and a half week gestation infant with so-called classic BPD, which essentially was a form of necrotizing bronchiolitis as well as airway and alveolar fibrosis. And so what Bill described was that in 1 to 3 days of age, it was stage 1, and he described 4 stages, and that was hazy lung opacity, which really which was indistinguishable from RDS, although there were early pathologic changes. And stage 2 was from 4 to 10 days of age, and what he described was marked, increased and persistent opacity of the lungs as we see here. So then stage 3 ranged from about 10 to 20 days of age, and there was continuing opacity of the lungs, but development of cyst-like changes. I say cyst-like because you'll see on some later CTs that these actually aren't actual cysts in the lungs, but rather emphysematous lung changes. And then stage 4 was in babies greater than a month of age who then had mottled opacity of the lungs with cyst-like changes, often hyperinflation, and sometimes cardiomegaly as well. So pathologically, when they correlated the 4 stages with pathology, initially on stage 1, the pathology was airway mucosal necrosis and atelectasis primarily. Stage 2, with a marked opacity, correlated with patchy bronchiolar and alveolar epithelial necrosis. Note the sort of marked airway component of this disease. There was a lot of airway exudate and also interstitial edema. Stage 3 pathologically corresponded and was described as bronchial and bronchiolar metaplasia and hyperplasia with focal emphysema, atelectasis, edema, and early fibrosis. And stage 4 correlated with bronchial ulceration and metaplasia, smooth muscle hypertrophy, and they were seeing emphysematous alveoli, capillary separation from the alveoli, fibrosis, and right ventricular hypertrophy, and changes of cor pulmonale. So what happened to these babies with BPD as they followed them up and as things evolved? Well, it turned out that there really wasn't a very strong radiographic pathologic severity, stage severity correlation. And that was true especially for the early stages. So BPD then became later defined more by the later stages and was initially defined as persistent oxygen requirement and radiographic changes beyond 28 days. And I remember that I used to teach the trainees, we don't call it BPD until they're about a month old. We don't give them that babies that label. Before that, we might talk about evolving BPD. So the current definition actually doesn't include radiographs at all and is based on supplemental oxygen use at 36 weeks post-menstrual age because that correlates better with pulmonary outcome. And there have been a number of modifications of that over the years. And again, other people will talk about that in more detail. Approximately 40% of the patients with severe BPD died. And in the survivors, there was usually clinical and radiographic normalization by age 2 to 3 years. So the lungs had a tremendous ability to recover. There was, however, increased susceptibility to respiratory illness, especially in the first year of life. And when Bill and others looked more carefully at older patients, more sensitive studies like CT and pulmonary function tests were often abnormal, even in asymptomatic children and into adulthood. So what happened to the evolution of BPD, the classic BPD? So unfortunately, despite major advances in neonatal care, some of which Dr. Sunshine has told you about, it was surprising that there was not really a decrease in the overall incidence of BPD. But what we did see was that, in fact, the thing was that much smaller babies were surviving, and they now account for most of what we see of chronic lung disease or BPD in infants. And in fact, 40% of babies less than 28 weeks gestation develop chronic lung changes. So these very low birth weight infants not only lack surfactant, like the classic BPD babies, but they also have very marked immaturity of airway, parenchymal, and vascular lung elements. Many of them are only in the canalicular or early saccular phase of lung development. They don't even really have alveoli yet. And so that has led to a number of changes in the clinical imaging and pathologic features of BPD. So that brings us to the concept of the new BPD, or some people prefer the term now of chronic lung disease of infancy. Here the concept is that there's a variety of insults similar to classic BPD that lead to an alteration actually now not just in a necrotizing bronchiolitis predominantly, but a change in lung organogenesis, which results in simplified alveoli, dysmorphic capillary configuration, as well as variable interstitial cellularity and fibroproliferation. So we don't see the classic ordered radiographic BPD stages that Bill Northway originally described. The lungs instead tend to remain persistently hazy, and then they gradually develop some reticulation and hyperexpansion. Cyst-like changes may still be seen in more severe cases, and pulmonary hypertension is a major problem in about a third of these babies and increases quite considerably morbidity and mortality. What does new BPD look like radiographically? This is a 27-week gestation infant. And so on day one, if we actually get a radiograph before they get surfactant, which is rare nowadays, you'll see the early picture of RDS with underinflated lungs and ground glass opacity. And then post-surfactant, as we see on the bottom left, those changes become a little bit coarsened as some alveoli re-expand and others don't, and often it's a little bit asymmetric, but overall the lungs are a little bit better expanded, a little more filled with air. And this baby on day 4, The lungs are actually show increased opacification, and we're seeing some pulmonary interstitial emphysema with streaky linear lucencies, so air leak in the lungs, which is not something we see all that often, but still a problem from time to time, and one of the factors thought to perhaps precipitate or worsen bronchopulmonary dysplasia changes. And then on day 10, this baby is evolving into chronic lung disease, has some persistent haziness of the lungs. On day 16, now there are reticular changes, but this baby also has one of the other problems that we see in these premature infants, is that there's a lot of shunting through a large patent ductus arteriosus, and some of the opacity we're seeing here is probably pulmonary edema as well. On day 30, this baby's had a clip placed on his ductus, and what we're seeing now is just some interstitial prominence, overinflation, and cardiomegaly, the fairly typical changes that we see with so-called new BPD, or chronic lung disease, which is described and classified as an alveolar growth disorder with deficient alveolar and vascular development. When we look at a CT, this is a CT scan on age 2 months on this baby. What we see are the features of that with overinflated enlarged lobules. Some of those so-called cysts are really just emphysematous, focal emphysematous changes, and those are surrounded by some dilated lymphatics and some fibroproliferative changes in the lungs. Another baby, this is a 28-week male infant with IUGR. Both male and IUGR are thought to be promoting factors for chronic lung changes. And day 1, the baby's intubated, has already received surfactant, so we just see some residual, slightly coarsened asymmetric changes, a little more on the right than the left. On day 15, on the bottom left, there's some right-sided atelectasis. On the left side, there's kind of coarse interstitial changes and maybe some interstitial emphysema, but evolving chronic lung changes. And at 6 weeks of age, in the top right, you see coarse reticular, fairly symmetric changes. The baby's still intubated. And at 5 months, somewhat asymmetric changes with asymmetric emphysema on the left side, and the left superior lung is herniating across the midline. This is a CT scan on this baby at age 5 months. Again, you can see the cardiomediastinal shift to the right side, the relatively emphysematous herniating left lung, but also the changes similar to what we saw in the other baby with these overinflated groups of alveoli, lobules, and some atelectasis, as well as some fibroproliferative changes. We also have a CT on this baby at age 10 months of age, where you see some of the changes have actually improved. There's less of the focal lobular changes, more atelectasis here, and still some emphysema and more diffuse emphysema and overinflation of the left upper lobe. There's a corresponding chest radiograph from 12 months. The baby has a tracheostomy in place and still has quite a lot in the way of clear radiographic pulmonary changes. But at 4 years of age, the lungs have actually almost normalized, although the baby is still trached at that time. So that's really sort of the quick Cook's tour that I had about 10 minutes to tell you about, and hopefully future research will further advance our understanding of the complex interactions that produce BPD, CLD, with translation into innovative and effective approaches to its prevention, mitigation, and treatment. And I look forward to hearing about these from the other speakers. Thank you.